What are the probe movements that should be used to distinguish between normal and true and a false positive suspicion of nuchal abnormality? What are the key ultrasound features that distinguish between normal and abnormal appearance of the fetal lungs? And what abnormality can be detected by correct assessment of neck and chest? I will not touch heart today because heart will be covered by another speaker later. So the learning objectives are, at the end of the lecture, you will be able to recognize the difference between normal and most common abnormal ultrasound appearance of the neck in the plane 6. Plane 6 is the transcerebellar plane, and recognize the difference between normal and most common abnormal ultrasound appearance of plane 7, that is in the chest, and excluding the heart. So as you know, the 20 plus 2 planes, we have 3 planes in the head, the plane 4, 5, 6. Plane 4 is for the transventricular plane, plane 5 is the transthalamic plane, and plane 6 is the transcerebellar plane. And in thorax, we have 4 planes. Plane 7, 8, 9, 10. Respectively, they are for 4-chamber, LVOT, RVOT, and 3-vessel trachea view. So as you see, fetal neck and fetal lungs, they have not been assigned with any particular planes, but we can examine fetal neck in the head, that is in the transcerebellar plane, and we can examine the lungs in the plane 7, that is for the 4-chamber view of heart. So these plane 6 and 7 are important for us today. And what abnormality we find in this plane? In plane 6, that is the transcerebellar plane, in which we take the measurement for the transcerebellar diameter, we can pick the diagnosis like skin edema, cystic hygroma, occipital encephalocele. And in plane, in the lungs and chest examination, we can find congenital diaphragmatic hernia, CPAM, that is the congenital pulmonary airway malformation, and pleural effusion, also pericardial effusion. So these are the scan pictures. I'll take the pointer. Okay, so these are the scan picture of head. This is the transventricular plane, this is the transthalamic plane, and this is the transcerebellar plane, and we are interested in this plane today. So this is an ideal transcerebellar plane where we can see the skull bone continuity, the midline falx is there, the CSP is there in the anterior 1/3, the anterior horn we can see here, and these are 2 thalamus here. These 2 are the cerebellar hemisphere, and behind the cerebellar hemisphere is the cisterna magna, and behind the cisterna magna, this small portion is the nuchal thickness or the neck part. And this is the scan picture of chest. This is the plane 7 and this is the plane 10. In the plane 7, we can see the 4-chamber view of heart and also the lungs here. And in the plane 7, this is for the 3-vessel trachea view, but we are interested in the lungs, which are at the side, and another organ here in the anterior mediastinum, that is the thymus. Now I will explain the probe movement. Can you see me?
Yes, we can see you.
Okay, so thank you. So the probe movement is easy, not like the movement of face. It is quite easy for neck. Simply you have to take the transventricular plane here from that is the plane 4. Simply you fix the anterior part and you just rotate the posterior part. Slight rotation will take you to the transcerebellar plane. From plane 4, slight rotation, plane cerebellum, this plane 6 will come. So this is the transcerebellar plane. As I already told, you have to see the structures that I have already described. And this is the plane where we take the TCD. Also, we take the measurement of the nuchal fold. To take the measurement of nuchal fold, you have to put the caliper from the posterior edge of the occipital bone to the posterior edge of the skin. Now these are the sagittal pictures of the neck. Here in this picture, this is the posterior part, this is the anterior part, and this is the head part is here, and this is the chest. And these are the spinal bones. Anterior to it is the esophagus, which is normally a collapsed structure we don't usually see, and this is the trachea, which is anterior to the esophagus. Well, we don't, in routine scan, we don't find, these structures because these are so small and collapsed thing. But when there is obstruction or when the pathology is very obvious, we just looking at the structure, we will get the pathology seen. Now, for example, in this structure, this is the head part and this is the anterior posterior part. This is the chest here. So there may be some obstruction here. That's why the larynx is so prominently seen and the trachea is so nicely seen here. And again, in this picture, this is the esophagus, which is so prominent. And the esophagus, it is forming a pouch-like structure. We call it the pouch sign, which is seen in case of obstruction. When there is distal obstruction, the fluid will be accumulated in the esophagus here in the neck region, and you will see a pouch-like structure. Now, what are the abnormality that can be diagnosed in the neck? So first, the most common was the nuchal edema. Second is cystic hygroma, and rare things are occipital encephalocele, cervical teratoma, and thyroid goiter. First, I will talk on nuchal edema. I have already told how to take the measurement. It is from the posterior border of the occipital bone to the posterior border of the skin. The cutoff is 6 millimeter in the second trimester, and when the thickness is more than 6, we will think of nuchal edema. It can be associated with the chromosomal abnormality. Most common is trisomy 21, can be associated with genetic syndrome, cardiac defect, skeletal dysplasia, congenital infection, many metabolic and hematological disorders. And the same when we see in the first trimester, we call increased nuchal translucency. So as there may be so many underlying cause, you need to refer the patient to a higher center where more detailed ultrasound and fetal echo is possible, and other investigation like invasive testing can be done. So these are the pictures. This is normal thickness here. Taken measurement is less than 6, but in this picture the measurement is 7.2 here. So this is a case of nuchal edema, and this is the first trimester picture where the NT is increased. Now the second diagnosis is cystic hygroma. Cystic hygroma, it is a defect in the formation of neck lymphatics, and the most common site is the cervicofacial region. In ultrasound, you will see bilaterally symmetrical cystic structure located at the occipital cervical region of the neck, and there is nuchal ligament, that is a septum-like structure, and it can be associated with chromosomal, mostly Turner, also trisomy 21, 18, and 13. Also genetic syndrome in 50% of cases. Also some congenital heart disease may be associated. It can end up with hydrops in 60 to 80% of cases. So investigation is a must in case of cystic hygroma. So these are the pictures. This is cystic hygroma at 19 week. You can see the cystic dilatation at the neck region. This is called nuchal ligament, and this is cystic hygroma at 28 weeks. The multiple septation are there, and the thickness is increased. So prognosis is usually fatal, and fetal death occurs in 90% of cases. But in case of isolated, sometimes rarely, it resolves with good prognosis. So many times we get confused with the increased, nuchal edema and cystic fibrosis. So to memorize, nuchal edema is subcutaneous edema, and cystic hygroma is due to, as I told, there is lymphatic derangement, abnormality in the lymphatics in the neck. In nuchal edema, there will be no septation like thing, but in cystic hygroma, multiple septation will be there. So these are some tips in ultrasound that we should remember to differentiate the two diagnoses. Now, occipital encephalocele. So it's a defect in the cranial bone through which the fluid or brain filled cyst-like structure pops out. The most common site is occipital, 85%, also can be seen in the parietal or frontal region. It can be associated with many chromosomal abnormality, genetic syndrome, or cranial abnormality. That's why referral and detailed examination and investigation is a must. So these are some scan pictures. This is the normal brain in the plane 6 section. Here in the early scan, in the NT scan, there is a mass bulging out, and the skull bone is, there is a disc here, and it is bulging out outside. And this is in a bigger baby in the anomaly scan, there is defect here, and this mass is coming out. So this is encephalocele. Now, cervical teratoma. So it's a tumor in the neck region, most common tumor in the neck region. It's vascular, solid, and with cystic components. So solid portion is here, cystic portion is here. Also, we can see, calcification spots here. And it is mostly seen in the anterior or anterolateral portion of the fetal neck. And after 26 weeks, there is usually rapid growth due to estrogenic effect. And when there is inward extension, the baby's head will be extended. There will be obstructed swallowing, forming polyhydramnios. So it is not associated with chromosomal or genetic syndrome, but a large tumor may complicate the pregnancy, causing anemia, thrombocytopenia, cardiac failure, and hydrops. Now, the thyroid mass or the goiter, which is not very common, we find rarely. So it's an anterior cervical echogenic mass of variable size, and mechanical obstruction can cause polyhydramnios. And when the mass is very big, we will see hyperextended head. And complications are growth restriction, tachycardia, heart failure, etc. There is no chromosomal or genetic association, and prognosis is good when the diagnosis is picked in time and proper treatment is given. So normally we don't see thyroid in neck, but just at a look, if the pathology is very obvious, we will see enlarged thyroid. So this is the transverse section of thyroid, and the thyroid gland is present between the two carotid artery. I think the picture is not very clear. This is one carotid, this is another carotid, and surrounding the trachea. The central one is the trachea, and this is one lobe of thyroid, and this is another. So this whole structure is the thyroid gland. And in the sagittal view, this is the mass, and this is the 3D picture where we can see the thyroid swelling. Now that's all about neck and neck pathology. Moving towards the thorax. So in the thorax, we will be talking about two planes, plane 7 and plane 10. This is plane 7 again, which is for the 4-chamber view. Also, we can see the lungs, and we will see lungs today. And this is plane 10, which is above, in which we will check the lungs and the thymus. And again, the probe movement is very, very easy, simple. From the transverse section of the fetal head, simply slide the movements to the caudal side. You will get the plane 7 section. And from plane 7, you will go slightly with the sliding movement, you go cephalad towards the head side of the baby, and you will get the plane 10. So this is the plane 7, in which we see the spinal bone at the back, 2 ribs at the side, the heart, which is slightly deviated to the left side, which is normal, and 2 lungs, which are at the sides of the heart. And this is plane 10, where we can see the lungs at the sides, and in front of the vessels, there is hypoechoic homogeneous structure, which is the thymus. And absent or hypoplastic thymus can be associated with different chromosomal abnormality, like most common being the Dijon syndrome and also Down syndrome. So that is the importance of seeing thymus. And again, this thymus, the lateral border is formed by the internal mammary artery. We can see this by using Doppler. And when the thymus is absent, the vessels will be pushed forward as if they are just retrosternal. Usually the vessel is at a distance when the thymus is there, but when the thymus is not there, you will find the vessels just at the retrosternal position. Now these are the parasagittal picture of chest. Posteriorly, we will see the spine, and this is the lung. This is the right parasagittal view. This is the lung. This is the diaphragm, dome-shaped diaphragm. This is the liver, and below which is the bowel we can see. And this is the left parasagittal plane, where this is the lung. Again, this is the dome-shaped diaphragm, thin diaphragm we can see. And bowel is here. Sorry, this is the stomach, and below that bowel we can see. And this is the coronal view. In coronal view, we can see the lungs, between which is the stomach, the 2 dome-shaped diaphragm we can see, and this is the stomach. These are the bowel structure. This is the coronal section of chest and abdomen together. Now, little bit of anatomy on the respiratory system to make you understand the pathology easily. As we know, this is very easy. This is the mouth cavity, which is opening to the pharynx. This is the nasal cavity. It is also opening to the pharynx. And this pharynx is just the posterior part of the mouth cavity. Below it, when the neck starts, we have two structures, the larynx at the anterior part and the esophagus and the posterior part. So this larynx and esophagus are present, important structures of the neck. And the larynx goes down, extends beyond, extends below with the trachea. The trachea comes down at the level of carina, it bifurcates to form the bronchus. Bronchus bifurcates to form bronchi, and bronchi bifurcates to form bronchioles. So this is the branching pattern, bronchus, bronchi, and bronchioles. Now, what are the what structures we normally see in the chest? So first is lungs, mediastinum. In mediastinum, we have heart, thorax, and structures like trachea, esophagus, and vessels like aorta, superior vena cava, inferior vena cava, and pulmonary artery. And in bones, we can see the spine at the back and the ribs at the side. Anteriorly, gyphoid process is there, and in the sagittal view, diaphragm we can see. Diaphragm, I think I have already shown you. And next important thing is the Cytus. Well, Cytus will be covered by, I think, Priti madam during her heart talk, but a little bit I will say, because it is also involved in the chest. Seeing at the first instance, the normal thing is the heart should be slightly towards the left side. So Cytus is all about the arrangement of normal organs inside the chest and the abdomen. Means the heart and this descending aorta, it should be in the left side, and in the abdomen, the stomach and descending aorta, it should be in the left side, and the liver and inferior vena cava, it should be in the right side. So seeing Cytus is very, very important, because abnormal Cytus can be associated with many abnormality. So in the first instance of the chest view, you should think of Cytus. So the normal lungs, they are bilaterally symmetrical, homogeneous, and there should be no mass or no, pleural effusion should not be there. And we can pick many abnormality from lungs. It can be intrinsic when the pathology is inside the lungs, and it can be extrinsic when the pathology is out of the lung. So the intrinsic pathology is CPAM, which is congenital pulmonary airway malformation, BPS or bronchopulmonary sequestration, chaos or congenital high airway obstruction syndrome, bronchial atresia, pleural effusion, pulmonary hypoplasia, and bronchogenic cyst. And in extrinsic pathology, the most common is the congenital diaphragmatic hernia. So one by one, I will explain. First, the CPAM or the congenital pulmonary airway malformation. So CPAM is a mass of abnormal fetal lung tissue formed during pregnancy. The blood supply is from the pulmonary vasculature, and it has communication with the tracheobronchial tree. It is three types: solid or microcystic type, macrocystic type, and mixed type. Solid or microcystic means there will be multiple small cysts of size less than 2 mm. Macrocyst is when there will be multiple cysts, but the largest cyst will be more than 2 mm. And mixed when both solid and cystic structure will be mixed together. So in the ultrasound, you will find hypoechogenic tumor inside the lungs of variable appearance. It is usually unilateral, and it involves one lobe or one segment of lung. There will be mediastinal shift, and polyhydramnios will be there. Hydrops occurs in less than 10% of cases. It is not there is no increased risk of chromosomal or genetic defect, but other system may be involved, like cardiac or renal. So you have to see the patient in the fetus. You have to do a detailed anomaly scan. So these are the scan pictures. This is CPAM here. The mass is here, echogenic structure, and this is solid mass, microcystic type. And same in the sagittal view. This is the diaphragm, and this is the stomach, means abdomen is, this is the abdominal part, this is the thorax, and this is the echogenic mass here. This is cystic type CPAM. We can see big cyst here, and same in the sagittal view. And we can see the blood flow coming to the chest. And this is the mixed variety of CPAM. So during pregnancy, CPAM size may increase or remain stable. And in 80% of cases in the third trimester, it regresses. The prognosis is usually good. Only when hydrops develops, there may be lethality. Now, the second diagnosis is BPS or bronchopulmonary sequestration. So it is due to non-functioning of non-functional lung mass, and it has no communication with the tracheobronchial tree. Sometimes it mimics microcystic CPAM. Means microcystic CPAM and BPS, they look alike because both are echogenic mass, right? And both are unilateral, but the difference is their blood supply. CPAM gets its blood supply from the pulmonary vasculature, whereas BPS takes its blood from the descending aorta directly. Now BPS can be extralobar or intralobar, and the mass regress or disappear during third trimester. It has it has good prognosis like CPAM. In ultrasound, you will see hyperechogenic mass. Color Doppler will show the feeder vessel. Sometimes hydrothorax and hydrops develops. There is no increased risk of chromosomal or genetic thing, but you have to see the baby in detail for other system involvement. So these are the pictures. This is the BPS mass, and this is the feeder vessel coming from the aorta. Now, congenital high airway obstruction syndrome or CAOS. This occurs due to agenesis or stenosis at the upper airway, that is at the trachea or larynx level. It can also result from the wave or cyst-like structure in the larynx. So the diagnosis part is very easy because once you see the picture of CAOS, you will not forget lifelong. You will see massively enlarged lungs, bilateral, and hypoechogenic lung. It will both the compressed, both the enlarged lungs will compress the heart at the center. The bronchial tree will be dilated, and the dome-like structure of the diaphragm will disappear. It will be more inverted. You can find ascites and hydrops, and there is no increased risk of chromosomal abnormality, but it can be associated with genetic syndrome in 50% of cases. That's why you have to evaluate the case, and the prognosis is mostly lethal with high mortality. These are the scan picture. This is the bilateral lungs are so enlarged, and this is the small heart at the center. This is the side view, the sagittal picture, the enlarged lung, and this is the ascites we can see. Here, the trachea is so dilated that it can be seen in the sagittal part of neck. And this is the dilated bronchial tree here, we can see. Normally, we don't see. Now, bronchial agenesis, if you remember the anatomy, if there is obstruction at the level of trachea or larynx, both the structures will be involved, means both the lungs will be involved. But if there is bronchial atresia in one side, one lung, it will be unilateral. One lung will be hyper enlarged and hyperechogenic, but the other lung will not be involved. But the enlarged lung will push the other mediastinum to the other side. So you will get the picture like this. This unilateral lung is so dilated, so enlarged and echogenic, and it has pushed the heart to one side, and other lung is not visible. So this is the bronchial agenesis picture, and it also has a high mortality. Now pulmonary hypoplasia. Hypoplasia or aplasia is a complete absence or hypoplasia of one lung, usually right one, because if there is bilateral pulmonary hypoplasia, the baby will not survive. So usually we find unilateral hypoplasia, and there is no increased risk of chromosomal abnormality. The pulmonary hypoplasia and the previous one, the bronchial atresia, they usually present like the same way. Only difference is in bronchogenic aplasia, you will get the lung which is very echogenic, but here see the lung is not echogenic. Otherwise they present same, like one lung will be there, and the mediastinum will be shifted to the other side. The last part is the pleural effusion. So the pleural effusion, there will be anechoic area around the lungs, and in case of severe pleural effusion, there is mediastinal shifting. 50% case are isolated, and 50% can have hydrops. So you need to evaluate the case and complete proper anomaly scan, fetal echo, and chromosomal study has to be done. So these are the scan picture. In this picture, the lungs are clear with no pleural effusion, but here you can see unilateral pleural effusion. The other side is okay. This side lung is surrounded by the effusion here, and this is bilateral pleural effusion. The last part is a rare thing, that is bronchogenic cyst. It is just a cyst in the lung mass with which is avascular with no signs of compression or no change in echogenicity. If you think of stomach bubble, like in case of congenital diaphragmatic hernia, you can see in the sagittal section the diaphragm will be intact and the stomach is here. There is no peristalsis. So this is simple bronchogenic cyst with no increased risk of chromosomal or genetic syndrome. But only thing, when the cyst is very big, it can have compression features and can lead to cardiac failure and high drops, but this is very, very rare. So now the last one, the congenital heart diaphragmatic hernia. This is due to herniation of the abdominal viscera into the thorax through a defect in the diaphragm. And there is mediastinal shift. The bowel, stomach, and the liver can be seen in the thorax. Polyhydramnios and hydrops fetalis may be seen sometimes. So these are different sites. Herniation can occur through anterior, central, posterior, right lateral, left lateral sides, but the most common is the left side, which is 85%. And time of herniation is variable. It can occur in the early second trimester to first hour of life. In 50 to 90% cases, it is diagnosed prenatally, not in 100% case. Now, one by one, we will see. This is the left side. In case of left congenital diaphragmatic hernia, you will see cystic structure in the heart that is due to the stomach bubble. There will be mediastinal shift. Peristalsis and fluid within the bowel will be seen if the bowels are also inside the chest. In few cases, the liver can also go up into the thorax. And in the abdomen, you will find the diaphragm, the contour is lost. There will be no stomach bubble inside the abdominal cavity, and there will be altered hepatic and umbilical vein course. So these are the scan pictures. This is the stomach, which is in the chest, and the heart is pushed to other side, to the right side. This is the bowels here, this is liver, and this is the lung in the other side. So this whole mass is coming from the left side, which is occupying the left side of the thorax, and the mediastinum or the heart is pushed to the right side. So this is the sagittal picture where the liver has gone up, and you can see the liver vasculature also. It is traveling from the abdominal cavity to the thoracic cavity. This is the Doppler picture. And in case of right side, the organ is liver only. So liver will be in the chest. There will be mediastinal shift to the left side. Already the heart is in the left side, but the heart will be in the extreme left. You can see the gallbladder also in the chest, which is diagnostic, and peristalsis and fluid will be seen if bowels are there. And in the sagittal picture, you will see the diaphragm, the contour of the diaphragm will be lost, and there is absence of gallbladder and altered orientation of the gallbladder. And one more thing, if you see the stomach, the stomach will be transverse due to the stretching during the herniation. This is the scan pictures. This is the heart here in the left side. In the right side, the whole mass is the liver, and we can see the gallbladder here. And this is the herniated liver into the right hemithorax, and pericardial effusion has formed in this case. And this is the stomach I was saying. This is due to stretching. When the herniation occurs, it will stretch the stomach from opposite sides. So there will be transverse stomach bubble. So this anomaly, this congenital diaphragmatic hernia can be associated with different chromosomal defect, genetic syndrome, and other system anomaly can be there. So you need to refer the patient for a higher detailed ultrasound and echo and assessment of the severity. And the prognostic factors are degree of pulmonary hypoplasia, position of liver, and severity of pulmonary hypoplasia. In case of severe condition, it is very, the survival is less than 15%. And in case of moderate condition, the survival is 50%. And in case of mild condition, if the good patient care we give, we will survive the baby more than 90%. And if it is part of trisomy, of course, the condition will be lethal. So these are the scan pictures. This is the normal lung and normal heart we can see here. This is the left-sided hernia, means stomach is here. It has pushed the heart to the right side. And this is the right side hernia where liver has come to the right side and pushed the heart to the extreme left side. So that's all. I'm at the end of the session. Am I audible?
Yes, yes, you are audible.
Yes, so silence is there, so I doubt.
No,
Okay, sir.
because,
Yes, sir. So I'm at the end of the session with the most exciting part. Everyone has to unmute and please participate. You have to give your feedback, what you feel. The first image, is it normal or abnormal?
Normal.
Yes, yes, sir.
Normal.
Yes,
Normal.
Normal.
So thank you. So this is the normal plane 7 picture where we can see the heart, the lung. This is the second picture. You have to tell me what is
Pericardial.
Bilateral pleural effusion.
Pleural effusion.
this is bilateral pleural effusion. Heart is here. Heart is here. 2 lungs are here, and around the lung, the effusion is there. So this is bilateral pleural effusion. This is the third picture.
Cows.
Yes, 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 yes. You got it. This is, yes, this is chaos. The bilateral lungs are so echogenic and enlarged, and it has compressed the heart at the center. And this is the fourth picture.
Yes.
Kennedy Shipam.
look at the heart.
CDH.
The heart. Where is the heart?
CDH. CDH.
CDH.
Yes, yes, sir, right. This is CDH. The heart is here, the stomach is here, and this is the bowel that is coming in the left side. So this is CDH. But of course, to diagnose CDH, we have to see the fetus in different view. Like we have to check for the stomach in the abdomen, and we have to see the baby in the sagittal view as well. Can you get this one, please?
Right side.
Yes, this is CPAM, right, sir? Well said. This is CPAM. Heart is here. So this is the hello. Okay. This is the lung mass, which is more echogenic, and this is the cystic structure. So this is the CPAM of lung, which has pushed the heart to opposite side. So this is the next picture.
Increased nuchal thickness.
Yes. So this is the transcerebral plane or the plane 6, and we can see the nuchal edema here.
Cystic hygroma.
Yes, thickness is increased, and this is multiseptate. So this is cystic hygroma. Yes, sir. Yes, yes. Correct, sir. Correct, sir. There is a defect in the skull bone here, and the mass is knocking outside. So this is encephalocele. And this is the last picture.
Cervical Teratoma.
This is the head portion of the baby. This is the neck, which is extended. We can see the solid portion, also calcified, so big. Okay, so this is the teratoma, which is rare.
Teratoma.
So at the end, sliding between plane 6, 7, 10 allows identification of the most common pathology of the neck and chest. Always double check the structure with a sagittal and parasagittal sweep. Verify echogenicity and homogeneity of the lungs. Your role is to distinguish between range of normal and abnormal appearance, and any appearance cannot confirm as normal should be referred for a more experienced opinion. So thank you so much for your patient attention. I hope Thank you so much.
Thank you, Dr. Rama, for a great presentation. It is very much appreciated. And we are really missing our expert comments of our team leader, Professor Shyama Kanungo. She is a great person and the initiator of this whole program. But she is on leave, and I think next Friday she will be able to attend. But, so we are missing you, madam. Means if you are listening somewhere, means just you can say 2 words about Rama. So anyhow, we are missing expert comments of Shyama madam. And Ashok sir, are you there?
Yes, very much. Yeah.
Shyama madam is on medical leave for
Yes.
2 weeks, so she is not with us. Next Friday, she is going to be with us.
I look forward to that, truly, yes.
So,
But
Sir.
we've had an excellent presentation
Thank you
and
so much, sir.
beautifully expanded from the original expectations. And it's really important to realize that what we have been teaching you so far is the minimum that we need to do. And in many situations, we have to go beyond the minimum. And because our situation is different from that they face in other parts of the world, like the United Kingdom. And in the United Kingdom, you just have to tell normal from abnormal and it goes to the expert. With us, we are the only people there in the whole scenario who is an expert. So we have to extend our knowledge, like those beautiful images that we saw from Dr. Rama Nayak. They were really an excellent selection of positive cases, very classical and going beyond the classic to the rare, so that we know that our mind is open. And yes, we have to keep on looking. We have the power of the internet. And now I'm really looking forward to the polls.
thank you, sir. Thank you so much.
Thank you so much, sir.
And only thing is, Dr. Rama should be speaking very slow, like Dr. Ratnapuri.
Yes.
I have heard Dr. Ratnapuri and another speaker, Lil Valentin, if you remember, they speak very slowly. Rama,
Yes.
you were going very quick actually. So next time be careful.
Yes.
Okay, thank you so much. And Sambit Babu, can we go to the post polls now?
Sir, can I ask one question?
Agya, pacharantu.
Sir, how can we definitely diagnose a case of TE fistula?
Tracheoesophageal fistula.
Yes.
Ashok sir. please.
Yes. So you see, the tracheoesophageal fistula has 2 components. Usually, one is the degree of esophageal atresia, and the other is the fistulous communication between the esophagus and the trachea. Now, depending on the type of communication, you may or may not be able to diagnose a tracheoesophageal fistula. So if you have a tracheoesophageal fistula, which is such that the distal part of the trachea does not communicate with the lower part of the esophagus, then that means it's not the H-shaped, then the stomach does not fill. That is easy to diagnose. And that is also the kind where you end up seeing the esophageal pouch sign, which is in the back of the thorax, anterior to the spine, and it fills intermittently. But if you have a H-shaped tracheoesophageal fistula, where you have a communication between the esophagus as well as the trachea, and then you have another communication lower down, where there is actually no esophageal atresia, then we miss that type of a tracheoesophageal fistula. At most, you might find a small volume stomach. So if you find a small volume stomach, you start getting suspicious and you wait and watch it for an hour, for 2 hours, for 12 hours, and for 24 hours. So persistently small stomach will tell you something wrong either with the swallowing or the fact that there is no communication between the upper part of the digestive tract and the stomach. But if you have a fistula which communicates, then of course, without any degree of esophageal atresia or distal esophageal atresia, then you can miss this completely on an ultrasound scan. So that is one of the known pitfalls of an ultrasound scan. You might pick it up in later pregnancy, in the 3rd trimester, because swallowing is never as good. And then you might pick it up as polyamnios and a relatively smaller stomach, but just as suspicious, not definitely not a small stomach. In that case, then we say, okay, you have polyamnios, you have a polyfilled stomach. I think that you should have a tertiary center delivery. So then your algorithm goes correct. But you're absolutely right that there is a certain degree of tracheoesophageal fistulas that will go undiagnosed and you will not be able to see them.
Okay, thank you, sir.
So do we go to the polls?
Post polls.
Yeah.
Are the participants, are you able to see the post polls?
We will have to click on the polling button.
Yeah.
No, sir.
Sir, if anyone else having any doubts or questions to ask.
Very difficult topic, no doubt.
That means Rama's done a very good job.
Sir, I have relaunched the polls
Right.
as no one is having any doubt. Participants may now attempt the poll questions. Thank you.
Again, the question number 2 is what is not a criteria for optimal plane?
6.
Yeah.
6. Please read it as optimal plane 6.
Good evening, sir. I'm Preeti here, sir.
Preeti, good evening. Good evening. How are you?
Yeah, so fine. How are you, sir?
Fine. So next Friday is Suchita Agrawal, and then next Friday, you are speaking on obtaining heart views.
Cardiac views. Yes,
Cardiac.
sir.
Okay, I think that.
So next session will be taken by Dr. Suchita Agrawal on abdomen, and I will take on next Friday.
Right. I already communicated this. Yes.
Okay, thank you so much.
And then cardiac views is very, very important, because the anomalies, cardiac anomalies, and the CNS anomalies are very common.
Yes, sir, it will take a bit long time also.
No problem. I think we will go through. Yeah.
Okay, thank you.
Not the question of time. It is a question of the interest we topic generates. And that's an important topic also. And
yes,
I hope that every listener will be eager to listen to your excellent talk, because that is your favorite subject. And you are for us, you are an expert in echocardiography. So Preeti Dubey, I send all my cases to her, So,
thank you so much, sir.
Rama had one interesting slide where she put 2 images in a dual screen. That one was the stomach on the left side and the cardiac apex pointing on the left side. So in the dual screen, she had shown beautifully the Cytus. So thank you, Rama, for that excellent slide. We will remember that.
But sir, I didn't go deeper, sir, because I think Preeti ma'am will also talk on this.
Yes, I will start with Cytus only. In heart, we have to start from abdomen only.
Yes, ma'am.
So we want more participants to go through the polls actually. And my request to all participants, don't leave till the end, because we will be analyzing these polls and also we will be coming to the right answers also and why it is so.
Yeah. Oh, that's the
We have now five modules, obstetric modules now. And I think then we will be completing the obstetric module, and thereafter we are going to 6 gynec modules. So Suchita will speak on abdomen and abdominal wall. Preeti is obtaining and interpreting heart views. And then we have distinguishing between normal and abnormal appearance of urinary tract. We have distinguishing between normal and abnormal appearance of long bones and extremities. And the final one, the 24th one, is we will show you a lot of images and ask you whether this is normal or not normal. Making a decision, that's we have to make a decision. And of course, it is very important that when we look at an image and we know that these are standard biometric planes and how they look like normally. So what happens is we are seeing, say, as I had told you, that 95% of the time we are not seeing abnormality. So only 5% of the time we will detect something which is not exactly looking normal. So our eyes has already been looking to a pattern of 95% normality. So what happens is, whenever we see something which looks abnormal, instantly we will know that, oh, this is something which is not, it is not looking right. So this is the thing. And once it is not looking right, either we solve it at our level or we refer the case. So say, for example, if you are seeing a goiter, like, so it is very important that, we can't know whether the fetus is really having hyperthyroidism or hypothyroidism. So what we do, we send it to fetal medicine specialist, Rama or Preeti Dubey, and they would really make a score out of that and find out what is the heart rate, what is the bone density, the ossification. Because in hyperthyroidism, what happens is the bone density is increased actually. In hypo, it is less mineralized. So these are, they make a score. Any score which is more than 2, it goes in favor of hyper. And it is very important that they give thyroxine. How do you give thyroxine? Preeti or Rama, both of any one of you can answer that. Intraamniotic thyroxine. Ashok sir.
Hello.
Preeti, suppose
Yes,
if you know that the fetus is having a hypothyroid state, or
Yeah.
sometimes what is confirmatory is.
What is confirmatory is the thyroid
Confirmatory is
swelling itself.
cordocentesis. Cordocentesis, you draw blood and then send it. Okay. Right.
Okay.
So after that, what do you do?
I have not done for anyone, but usually in Mediscan, they used to give intraamniotic thyroxine.
या आप उसको कैंसिल कीजिए. कितनी बार फोन करेंगे आप लोग? 100 बार हो चुका है. So distinguishing the normal and abnormal is very, very important. And we will instantly know that, yes, this structure, this plane, it doesn't look normal. And in the 20 planes, as we have already discussed, we have discussed that 50 abnormalities we can already see in 20 plus 2 planes.
So now we can discuss the postpone questions.
Okay, we can discuss the postpone.
Yes, sir.
Okay. So question number 1 is neck can be examined in which plane of head? The correct answer is, already Rama has said that plane number 6 is the correct plane, because that is from where we look at the posterior aspect of the neck for nuchal fold, and we decide about any abnormality. So plane 6 is right answer, and 89%. We are very happy that yes, you have grasped the subject very clearly.
And sir, the pre and post orientation poll response improvement is from 50% to 89%.
Oh, it is tremendous. Very good. Lovely. So the question number 2, what is not a criteria for optimal plane number 6? Because the 6 is missing, we had communicated that what is not a criteria for optimal plane 6. The right answer is both the lateral ventricles should, I mean, it is not important. We don't look at the, because they will not be visible during in the, yeah. So both the lateral ventricles are, that is the right answer. And I think 59% of the people participants have made it right. So
The pre to post orientation poll questionnaire response difference is not that much, but only 56% to 59%.
Right. So the question number 3 is chest is assessed in the following planes 7 to 10. I think 93% of the participants have attempted it right. 93%. And plane 7 to 10 is the right answer.
And the pre and post orientation poll difference is from 64% to 93%.
Great improvement. So question number 4, the common anomalies detected in plane number 6 are, Rama had already shown all the nice diagrams that in plane number 6, cystic hygroma can be diagnosed, occipital encephalocele can be diagnosed, skin edema and lymphangioma can be diagnosed. So all of the above is the right answer, and 96% of the participants are right.
The pre and post orientation response difference is from 78% to 96%.
Great improvement. Yeah. Question number 5. What are the structures seen in normally in fetal chest? What are the structures normally seen in fetal chest by ultrasound? So all the above is the right answer. All the above, because we can see lungs and heart, we can see thymus anterior to the 3 vessel trachea view, we can see the trachea, we can see esophagus, we can see arteries and veins, spinal bones, xiphoid, diaphragm. So all of the above is the right answer for question number 5, and 96% of participants are right.
Pre and post orientation response difference is from 92% to 96%.
Great. 92. They already knew the subject before, actually.
Yes.
Okay. Thank you. So question number 7. Is it we are going to 7 or 6?
6, sir.
So we are going to 6. Abnormalities that could be excluded after correct assessment of the neck are all except. So Ashok sir beautifully explained that tracheo, and I think one of our colleague, participant had asked interestingly the question also about TE fistula, tracheoesophageal fistula. It will be very difficult to diagnose. It cannot be excluded. So C is the right answer. Abnormalities that should be excluded after correct assessment of the all except. Yeah.
Sir, actually, there is a dip in the response, the correct response. Pre-orientation, only 51% of the participants have responded correctly, and in post-orientation, 33% of the participants have responded correctly.
Right. So now it is the question number 7, is it?
Yes, sir.
So most common lung anomaly, and Rama had already told about CPAM, the congenital pulmonary airway malformation is a cystic lesion, microcystic, macrocystic. This is the commonest of the lung anomaly actually. So I think 83% are correct.
The pre to post orientation improvement is from 68% to 83%.
Yeah, great. Yeah. Now, question number 8. What is wrong about congenital diaphragmatic hernia? So the alternatives where CDH is more common on left side, well, that is very common, that is right. Liver herniation has poor prognosis, that is right. Not always lethal because there are treatment available in centers. So in left-sided CDH, stomach is always in the chest. It may not be always, even without stomach, because there could be a gap, and stomach, instead of stomach, we may see some bowel or the left lobe of liver herniating through the hernia, and stomach may not be seen. So that is the exception. Rama, am I right?
Yes, sir.
Okay. So 50% of the participants have attempted it right, that in left-sided CDH, stomach is always in the chest. That is the wrong. That is wrong. 50%. Sambit Babu, what was pre-poll?
The pre and post difference is from 53% to 50%.
53 to 50. Okay, so some people change their mind actually. So
Sir, I guess there is some doubt in the question framing of the question. So
what is wrong about CDH? Anyhow, so let us go to the question number 9. Which of the following present as echogenic lung mass? So CPAM, bronchopulmonary sequestration, and atresia. All of them actually for that matter, all of them are echogenic.
Yes, sir.
So 85% have attempted it right.
the pre and post orientation difference is from 58% to 85%.
Great improvement. Yes. So now here comes the end of our post poll. And which of the following present as cystic lung lesion? Again, we have differentiated. Rama had already said that basically CPAM, CDH, these are basically cystic lesions. They are all cystic lesions. Some of the cysts may be micro, some of them may be macrocystic. So bronchogenic, again, she has shown a beautiful slide. So all of them, all is the right answer. And 61% of participants have attended. 61%.
The
61%.
pre and post orientation difference is from 53% to 61%.
There is a great improvement. So Rama, you presented it with a great clarity. I really thank you and congratulate you. And we will be eager to listen to you again and again. We really miss expert comments from our team leader, Professor Shyama Kanungo. She is doing very well. And we wish her a quick, she's on a medical leave. We wish her a very, very quick recovery. Get well soon, madam. And be with us next Friday. We will be eagerly waiting to listen to you again. And yeah, thank you again, all my listeners,
Sir,
friends.
Sir, Padmalochan, sir, Dr. Padmalochan Mahanta has requested for reviewing of esophagus. The slide containing esophagus.
Okay, I think Rama, can you come back to your slide again? Please have a view of esophagus again and yeah.
This
So this is in case of atresia or obstruction. Rama, please comment.
Yes, sir. So normally we don't, in the routine scan, we don't look for esophagus or trachea. As I told, if the pathology is very obvious, then it will be seen. Like in this case, when there is obstruction beyond, the fluid will be accumulated inside the esophagus and it will be seen in the neck, like a pouch. That is called pouch sign in the neck.
And once you see a small stomach, you will
Definitely,
Yes,
definitely. Yes,
yeah.
sir. Associated factors.
Sir
Like,
has already beautifully explained everything so nicely.
yes.
So is that clear? And I think one of our participants had asked about measurement of nuchal fold, and I think Rama told the same thing as it is. Nuchal fold thickness measurement is taken from outer edge of the occipital bone to outer edge of the skin. I think Rama also made the same statement. So
Yes,
yeah,
sir. Outer to outer.
Outer to outer. So Ashok sir, we are very grateful to you. You have been encouraging us in this great, attempt of ours to share our expertise with our specialists here in our state of Odisha.
Yes.
And we look forward again, that all your expert comments are very valuable to us. And I also would say to all participants that, we have in SFM, Society of Fetal Medicine, we have a lot of, and any of you, all of you means in the sense that we must know genetics very well. And we have a beautiful 8 recordings available on SFM site and so many others actually. So I would request that all of our participants should be SFM members, and then you could have access to a lot of information, which we are actually, Ashok sir, let me, this is a fact also, you also know, and I also know that membership of our SFM is very, very economical.
Very economical. It's
very, very
amongst the
extremely
least
economical
in the world. Yes.
In the world. Actually, we are not taking a huge sum actually, and it is for we have 10-year membership, we have lifetime membership.
Yes.
And when we compare with other societies, I think our society is 1/100th of what we are paying to other societies.
Absolutely, yes.
So and the
It's
content
really
is
worth becoming a member because we are all like-minded people.
yeah.
And we all like to learn. We even have the SFM YouTube channel that is free for everyone, of course. But there are some recordings which are only for members. And those are some very nice basic to advanced recording. They will all be able to get their answers there.
And our webinars are going great. I think this time I was also listening. I was not able to participate, but I really wanted to give comment. But I was actually during that time doing something and then listening to the great talk of Lakshmi Ravi about
The face, the orofacial
cleft palate. It was a great talk. I think these are the type of webinars which will be very, very helpful. And from basic, actually, all our participants should really go to the advanced ones also. So this is our aim.
Yes, they will get inspired.
Sir.
Wonderful session today. Thank you so much.
Thank you, sir. Thank you again. And
thank you, sir. Thank you all.
Thank you so much, sir.
Thank you, sir.
Well done, Rama. Very well done.
Thank you so
We
much.
all are looking forward to meet you again, sir.
I will do so. I will be coming. Thank you. Thank you.
Thank you
indeed.
so much, sir.
Namaskar. Namaskar.
Namaskar, sir. Thanks.
Namaste, sir.
Thank you all participants also.